Hello everyone and welcome to today's live broadcast, Keynote presentation, Tumor Re-oxygenation, Basic and Therapeutic Considerations, presented by Dr. George Perdrizet, the Professor and Endowed Chair in Hyperbaric Medical Research in Emergency Medicine at UC San Diego Health System. I'm Susie Valdez of LabRoots and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time during our presentation. Just click on that green Q&A button located at the lower left of the presentation window and type your questions into the box that appear on the screen. Dr. Perdrizet will be following up with your questions via email. Also, please notice that you'll be viewing the presentation in a slide window. To enlarge that window, just click on the screen icon located at the lower right. If you have any trouble hearing or seeing the presentation, click on the support button at the top right or the Q&A button and let us know you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the button in the bottom left-hand corner and follow the process to obtain your credits. Without further ado, please join me in welcoming our keynote speaker, Dr. George Perdrizet. I will now turn the presentation over to him. Welcome, Dr. Perdrizet.
Welcome. I'm Dr. George Perdrizet from the Emergency Medicine Department at UCSD. Where I chair the translational research program in hyperbaric medicine. Today I'd like to review with you the opportunity to use tumor reoxygenation in therapy and to review some of the basic research related to this. So to orient us to the tumor microenvironment, I use this picture diagram of the cellular components that can be found within a tumor microenvironment, and you can appreciate the variety of cells as well as the complex interactions between cells. We have resident tumor cells, somatic resident or host cells, along with inflammatory cells of different sorts. And there's complex interactions that are occurring between all of these different cells. And as the tumor progresses, the oxygen tension within this area decreases and throws another level of complexity into the tumor and host interactions. And this is depicted here in this diagram where the perfusion of a tumor occurs in a graded response. The microvessels penetrate from capillaries inward, and as we go through a zone of low oxygen tension and then ultimately to necrosis. And the important point of this picture is that as the tumor grows, there's a severe selection pressure that happens on the malignant cells that really drives out a malignant phenotype, and this malignant phenotype is characterized by resistance to all forms of therapy. This is an example of a renal cell cancer that's in a hypoxic state. So this is how we would visualize oxygen tensions within experimental tumors. This is one method where a dye is injected, and the green represents the capillary, the black is well perfused tissue, and then the red is the hypoxic tissue. And again, this is the zone where we know there's resistance to cell therapy, and this is really the target in which we are looking at to reoxygenate. We're familiar with the cascade of oxygen delivery from the air. We breathe at 150 millimeters or 21% through the lungs and vascular system down to the level of the microcirculation in tissue, where we're at about 3.5% or 25 millimeters of mercury. For purposes of this presentation, hyperoxia will be defined as greater than 150 millimeters of mercury, normoxia 20 to 150, and then hypoxia is 20, but understand that hypoxia as a dynamic definition indicates that there is demand is exceeded the supply of oxygen and leads to disease. The tumor microenvironment, as I pointed out, due to poor perfusion, we see barriers that result in decreased drug delivery to tissue. However, the hypoxia further reduces the responses to radiation, drug, and immunotherapies, and the hypoxia sets up a chronic inflammatory state which further reduces immune responses within that microenvironment. And finally, there's a severe metabolic derangement characterized by both anaerobic and aerobic glycolysis that is the subject of this well-written textbook by Dr. Zifri from Boston College, and I will not get into the metabolic aspects any further. This is an example of hypoxia within human tumors. This is work from Dr. Peter Vopel from Germany, who's spent a lifetime charting and characterizing tumor hypoxia in humans. This is a histogram with the frequency versus the oxygen tensions. And as you can see, and this is normal breast tissue, there's oxygen tensions that would fall mostly into the normoxic range. As we find in breast cancer and in cervical cancer, this histogram becomes skewed to the severely hypoxic end. This can further be demonstrated in growing tumors that, as they grow, increasing volume leads to hypoxia. So this is an experimental tumor model where the histogram shows normoxia. However, once we reach approximately 1 centimeter of tumor volume, oxygenation begins to fall off and hypoxia dominates. So what we know is hypoxia is linked to poor clinical outcomes. This is related to tumor aggressivity, therapeutic resistance, and poor clinical outcomes. And again, I would refer the audience to work done by Dr. Vopel and his group. More recently, it's been recognized again that hypoxia within the tumor microenvironment is driving the malignant phenotype, and this has been popularized now by Dr. Smenza, who is the founder and discoverer of the HIF-1 alpha gene. This is another example of the effect of hypoxia on radio sensitivity, and this is disease-free survival in years, head and neck radiation therapy, and what's found is if the tumor has an oxygen tension of less than 10 millimeters of mercury, then the disease-free survival drops off significantly. So we know that hypoxia also induces inflammation. This is a major second downstream effect of hypoxia, and that inflammation itself contributes to the malignant phenotype. And so we all are familiar with the severe amount of edema and swelling and inflammation associated with solid cancers. This is one example of a brain tumor demonstrating severe tissue edema. This has been reviewed in this nice monograph and has been now studied in terms of identifying mechanistic links between hypoxia and inflammation. And one example here, human monocytes, when exposed to chronic hypoxia, become pro-inflammatory. We also know that during hypoxia, tissue is damaged, mitochondria become damaged and release their contents. This actually mimics very much what happens during a bacterial infection, where so-called PAMPs are released and are pro-inflammatory and induce a inflammasome type reaction. Well, the same thing is happening in a sterile environment under low oxygen tension. We see a damage to the mitochondrion and a release of mitochondrial DNA, which has a very similar effect to stimulate inflammation. This has further been shown that hypoxia will, by causing injury, will release these damage-associated molecular patterns and stimulate the TLR receptor, which then triggers NF-kappa beta, and again, we have a huge release of cytokines and inflammation. And so I've just shown you that hypoxia induces inflammation, but we also know that inflammation in turn will stimulate and induce a more profound state of hypoxia. And thus we have a positive feedback loop occurring. This hypoxia, inflammation-inducing hypoxia, was described in the 80s in the context of infectious diseases. And this is a wire mesh cage that was implanted subcutaneously, and one that is not infected, and then a cage that is had bacteria introduced to mimic infection. And what you can see is a significant reduction from 63 millimeters of mercury partial pressure down to 4.5, or hypoxic region. So we know inflammation induces hypoxia. Another example of that is the human tuberculin reaction. This has been well worked out by a group in Scotland, where they looked at transcutaneous oximetry overlying a positive human tuberculin reaction and counted the cell density. And as cells migrate, the increasing cellular number is associated with reduced oxygen tension. Again, an example that inflammation is inducing hypoxia. One mechanism that is well worked out and has been known for many years is the so-called respiratory burst, where a white blood cell, neutrophil, will consume oxygen at prodigious levels to produce reactive oxygen species that are then critical for killing of bacteria. So this is a highly conserved and a very potent response. In addition, inflammation further causes tissue edema. This leads to diffusion barrier or blockade, and perpetuates or exacerbates the hypoxia. And also the inflammation leads to microvascular injury, and likewise further reduces the oxygen tension within the tissue. So this positive feedback loop is referred to as inflammatory hypoxia, and it is a self-fulfilling positive cycle, which, independent of whether inflammation starts causing the hypoxia or hypoxia starts causing the inflammation, the two of them then build on one another, and a irreversible cycle is established. This has gotten recent press and interest by Dr. Eltzig from University of Colorado, who's elegantly described this relationship. And what we know is there's a profound amount of molecular crosstalk and potential targets that are common to both inflammation and hypoxia. I've recently put together the concept that many diseases, not just cancer, are suffering from a problem of inflammatory hypoxia, and that tissue reoxygenation has a potential for opening new therapeutic avenues. So, overcoming the inflammatory hypoxia barrier, drug therapies have been tried: anti-inflammatory drugs, immunotherapies, hypoxia sensitizers, and nanoparticle gene therapy, all of which have some modicum of effect but are not robust. So we know the predominant way that inflammatory hypoxia is treated today is with drugs, anti-inflammatory drugs, ignoring largely the other half of this equation, or this cycle. And we wondered if adding in hyperbaric oxygen, or reoxygenating tissue, and will eventually require hyperbaric doses to effectively do that, might not influence and be able to break this vicious cycle. Tumor reoxygenation therapy began many years ago in the 70s, when it was recognized by Dr. Gray that radiation killing of tumors was very sensitive to oxygen tensions, and he called this the oxygen enhancement effect. This was shortly thereafter taken into the clinic where Churchill Davison began treating patients with tumors in a hyperbaric chamber at 3 atmospheres of oxygen, and was able to compare, was able to irradiate half of the tumor volume while in the hyperbaric chamber, and they showed significant killing of the hyperbaric exposed tumors. This is just one example of early work showing survival versus radiation dose, and in 150 millimeters of mercury, human pancreatic cancer, xenograft is very sensitive to the effects of radiation, less so at 40 millimeters and even less so in a hypoxic environment. This was then tested in an animal model, and these are historical work that shows an animal that had sarcoma injected into both limbs. This limb was irradiated while the animal was breathing hyperbaric oxygen, and this limb while the animal was breathing air. And as you can see, the dramatic effect, anti-tumor effect, that the combination oxygen and radiation has had in this model. This was then, again, by Dr. Churchill Davison, tested in patients, and in this one report, 8 patients were studied, and all tolerated this treatment without adverse effects, and 6 of the 8 showed significantly increased tumor killing. This then had its heyday in the early 70s, where a number of programs began irradiating patients through monoplace chambers, and there were some technical difficulties around this approach. More recently, the effects of hypoxic modification on radiation responses have been reviewed in this meta-analysis. And as you can see on this Foster plot, that both local, regional, and disease-specific survival improve if you modify the hypoxic environment. Now, the modification came by several methods shown here. One is by normal baric oxygen therapy, showed a mild improvement. To the left of the no effect line means that the hypoxic sensitizer is active. Hyperbaric oxygen actually showed the largest effect in terms of loco-regional control, and a number of hypoxic sensitizers had minimal effect. Again, in terms of disease-specific death, the same pattern is seen, a small effect with normal baric, a significant effect with hyperbaric, and a limited to no effect with the hypoxic sensitizers. The other point I would like to make with this slide is you can see the total numbers here. The normal baric oxygen is 377, 299, and then over 1,000, 1,600 patients. And one of the barriers to hyperbaric oxygen therapy is just that these are difficult studies to perform, and therefore sample sizes are typically smaller when compared to drugs. More recently, a renewed interest in incorporating hyperbaric oxygenation has appeared for supporting radio, chemo, surgery, in multiple malignancies, including brain. This is a recent report, feasibility abstract that was done from Dartmouth, and again showing that hyperbaric oxygen could be combined with chemoradiation protocols without with a significant change in adverse events. Another study, recent study from Japan, showed an identical thing, that adding in hyperbaric oxygen to chemoradiation is feasible and safe. So one of the biggest concerns about the use of hyperbaric oxygen in the setting of malignancy is, does it cause or promote cancer growth? Dr. Feldmeyer, who is a radiation oncologist, has studied this and reported on this extensively, and continues to find no positive effect of hyperbaric oxygen in the setting of cancer therapy. Data that I like to quote is from early work by Dr. Robert Marks, who used hyperbaric oxygen to treat oral maxillofacial injury from radiation, so-called ORN. And what we're seeing here is a 5-year follow-up of those patients by stage, whether they received control, no hyperbaric, or hyperbaric. And what we find is there's no significant difference in the recurrence at any stage over 5 years if a patient had received hyperbaric. And as you know, there's residual disease in many of these patients, and if hyperbaric was going to stimulate tumor growth, it should be seen here. When investigators have gone to the laboratory to look specifically at this question, they have failed to find a positive tumor-promoting effect of hyperbarics. Another concern about its use, especially in the setting of radiation therapy, is that the patients are inside the chamber, and when they leave the chamber, they quickly deoxygenate. The tumor quickly deoxygenates, and so any adjunctive benefit is quickly lost. This is one example that shows tumor deoxygenation. This is the skeletal muscle that deoxygenates quickly, but the tumor lags, and it's likely due to dysfunctional microcirculation, and that once the tumor gets saturated, there's a time period where the oxygen tension remains elevated. So what about tumor immunology? Is there a role for reoxygenation? As we know, early work showed the microenvironment was immunosuppressive, and that was led to some dismal outlooks in terms of immunotherapy. However, recently with the immune checkpoint inhibitors, there's been new and improved outcomes. However, this demonstrates again that there are associated with any of these therapies new barriers, all related to drug delivery, toxicity, and resistance. This is one diagram that shows the immunosuppressive environment that gets established due to the hypoxia. Adenosine is involved in this response, but we get Treg cells and immunosuppressive macrophage phenotypes that get driven out and really inhibit any type of immunotherapy within that tumor microenvironment. Efforts have been made to break that immunodepressed state by both chemo and radiation, adding chemo and radiation therapy to the tumor microenvironment. And more recently, this paper appeared where investigators had provided supplemental oxygenation to enhance anti-tumor effects of their immunotherapy. And this approach was suggested by their prior work, in which hypoxia was shown to drive increased adenosine receptor signaling within the tumor microenvironment. And this depicts an experimental lung model of methylcholanthrin-induced fibrosarcoma. And these are lung metastases, and these animals were treated with 21% oxygen or 60% oxygen on day 11 after implantation of the tumors, or at day 0. And what we can see is a dramatic number of cancer deposits within these lungs, with a significant reduction due to 60% oxygen, and a further reduction if the oxygen was started early. And this is depicted here with a very significant reduction. Survival was also improved by the animals that had received the supplemental oxygen therapy, and they also applied it to a spontaneous lung metastatic cancer and found the same oxygen effect. A quick review of drug synergy that's out there. Again, multiple cases. I only put these here for reference, but there's multiple examples of where hyperbaric oxygen will synergize with conventional or chemotherapy to kill cancer cells. And more recently, a interesting paper has shown that by modifying the diet and providing a ketone-based diet, the addition of hyperbaric oxygen again shows significant improvement in survival and survival time in the setting of this dietary manipulation. So why hyperbaric oxygen to reoxygenate? We know that it's purely about a concentration gradient, and while normal baric oxygen will achieve some reoxygenation, it won't be complete. And in order to get effective or maximal cell killing within solid tumors, we believe hyperbaric oxygen doses are going to be required. So I want to address some of the knowledge gap around hyperbaric oxygen for those of you who may not be familiar with it. It is a drug. It's considered a drug. It is widely available and safe. It will overcome this diffusion barrier. It also has a direct anti-inflammatory effect that is not seen with normal baric oxygen. As I showed you, it has potential to synergize with all forms of anti-cancer treatment. It also leads to a reduction in tissue edema and can reduce reactive oxygen species liberation in compromised tissue. The FDA considers hyperbaric oxygen therapy actually a combination therapy. The drug is oxygen, the device is the chamber. There's labeling specifically related to normal baric oxygen therapy. The hyperbaric oxygen therapy is depicted here. We dose this according to partial pressure, and the green represents the oxygen. This is 21% oxygen at 1 atmosphere of pressure. And as we increase the partial pressure just by normal baric oxygenation, all of the gas is now oxygen, and then we further increase the density of that gas by increasing the barometric pressure to 2 or 3 atmospheres. And this drives the partial pressure of oxygen to very high levels. This is a typical therapeutic algorithm that is used to treat patients for carbon monoxide poisoning with increasing pressures up to 3 atmospheres. The green represent oxygen. The yellow bars are the air brakes that are used to minimize CNS oxygen toxicity. Again, normal baric hyperoxia is 21 or 22 to 100%, and then the hyperbaric therapeutic range is 1.5 to 3 atmospheres. This is delivered by way of rigid pressurized devices, a monoplace chamber, a multiplace chamber. There's a lot of confusion in the lay press around these other devices. This is a home hyperbaric air unit. There's no oxygen except what's in ambient air, and it's 1.1. It's pressurized to 1.1 atmospheres. Topical oxygen is pressurized. Again, this is 100% oxygen pressurized to 1.1. These are not hyperbaric treatments, and they have not been approved by FDA. I want to take a minute just to talk about the therapeutic wedge that hyperbaric oxygen offers that is unique, and that's this oxygen hemoglobin binding curve that we all learn in medical school. And we're told that we basically the oxygen bound to hemoglobin is the significant part of the oxygen carrying equation, and the oxygen dissolved in the serum is negligible. And that's very true at less than 1 atmosphere of pressure. However, this becomes the driving force behind hyperbaric oxygen therapy, because it's the dissolved oxygen that actually leaves the red blood cell and the microcirculation to penetrate tissue and arrive at the site of action. And so the higher the dose of dissolved oxygen we can achieve in serum, the further we can penetrate diseased and compromised tissues. This is seen in this example. Again, histogram here. This is oxygen saturation, increasing oxygen saturation, and then just the frequency of the samples. These are experimental solid tumors. And what you can see is at normal baric air, there's a large number of hypoxic samples. But as you increase the oxygen to 100% oxygen or 2 atmospheres, and then finally to 3 or 4 atmospheres, the histogram is skewed way over to the right, to the highly saturated region. What's important about this is you're reoxygenating the tumor, but you're also changing the low end of the range. And if you look at the percentage of the cancer that had less than 5% saturation, we see in air it's about 16%, and this represents the refractory tumor cells that resist therapy. And if we can increase or decrease this fraction, we can expect enhanced tumor responses, anti-tumor responses. So again, this is just to point out that 100% oxygen may reoxygenate some tissues, but it doesn't achieve the end in mind. This is 3 liters of oxygen and 6 liters of oxygen that were administered to try to drive up peritumoral and intratumoral oxygen tensions, and you can see we see no significant change. However, with hyperbaric oxygen, we can drive the partial pressure of oxygen up into that tissue, and then once they leave the chamber, there's a decay, again a decay that is approximately 20 minutes or so. This is probably the single most important therapeutic slide that I have, and it's a distillation of years of work from University of Pennsylvania looking at the human toxicity profile of oxygen. And this green bar represents 100% oxygen that is available to hospitalized patients. And as you can see, with 100% oxygen and with time, this is the pulmonary toxicity curve. It approximates pulmonary oxygen toxicity, and we know that 100% oxygen beyond 24 hours, we start to see pulmonary injury. This is long exposure, low partial pressure. Hyperbaric oxygen works on the other end of this equation, or this scale, with a very short exposures but high partial pressures, and we're well away from the pulmonary oxygen toxicity. However, we do approximate the CNS oxygen toxicity, and there is a potential to have a grand mal seizure with this therapy. However, years of testing this and using air brakes, the risk is less than 1 in 8,000 treatments. So now what I would like to do is quickly just say why, additional evidence for why we think hyperbaric oxygen is a unique therapy. And this is because it has direct anti-inflammatory effects. And as I told you, we're trying to reverse hypoxia, but we're also trying to decrease the inflammation within that tumor. And hyperbaric oxygen has been shown to directly inhibit inflammatory responses. One example of this is bovine endothelial cells, or human endothelial cells, when exposed in vitro to hypoxic conditions, will develop increased expression of adherins, so-called ICAM1 in this example. But the important point is that if the same cells are exposed to the hyperbaric oxygen, it will reduce any kind of increased expression in the vascular endothelial cells, so it can reduce white cells sticking to endothelium. This is an animal model. It is a chemical colitis model, which shows that if you develop inflammation and edema and colonic weight increases. However, if you expose the animals to the same toxins but treat with the hyperbaric oxygen, you can see a significant reduction in the weight, suggesting that there's decreased inflammation. These authors further looked at inflammatory cytokines, which I don't show you here, and they were likewise reduced. Another example that points out drug synergy is a carrageenan model of inflammation in a rodent. And what you can see here is this is time, and this is swelling in the foot pad. And in saline-treated animals, there's significant swelling over time. Anti-inflammatory medications reduce this somewhat, but are not complete. hyperbaric oxygen alone actually reduces that inflammation and swelling greater than the anti-inflammatory, and when combined with the anti-inflammatory gets the best response. In humans, this has also been shown in a blister, a human blister model that involves UV irradiation, and what we see here again is this is the time, this is the size of the punch biopsy, and what you can see is, or the size of the blister, what you can see is the inflammation is very high in the first 24 to 48 hours. However, if the patients receive hyperbaric oxygen, it is suppressed. And then finally, systemic inflammation that's associated with inflammatory bowel disease was studied in the late 90s, and this just shows that at the initiation of therapy, very high levels of IL-1, treatment with hyperbaric oxygen reduce those systemic levels, and then it drops back up with cessation of the hyperbaric treatment. This is true for IL-6 and for TNF. So this is demonstration in a human that systemic inflammation can be reduced by using hyperbaric oxygen. So the anti-inflammatory effect is a intriguing and important secondary effect of hyperbaric oxygen. And this is not seen with 100% oxygen. So we wondered if you were to add hyperbaric oxygen to break both, to attack both of these limbs, would you have improvement in cancer responses? Others have gotten interested because of the cumbersomeness and the difficulty of using hyperbaric oxygen and the need for rigid chambers, developing drugs that will mimic reoxygenation, and all of these show, as you would expect, that if you can increase the oxygen tension within the tumor, you can improve therapeutic responses. I find this seminars in cancer biology and review of modulating the tumor microenvironment interesting. There are many natural products that are being tested. However, they fail to address the natural product of oxygen in this elegant review, and I suspect many of the compounds that they propose to use, again, will be impaired in terms of tissue penetration within solid cancers. So in summary, I'd like to say that the tumor microenvironment is a major barrier to the treatment of all solid cancers. Oxygen is a drug that can be dosed and delivered in a controlled and safe manner, and tumor reoxygenation therapy may synergize with radiation, chemo, and immune therapies. This is the final diagram to show you the model that we're thinking of, and we think that the oxygen is going to synergize with existing therapies. So I could place radiation and immunotherapy here as well, but that we suspect we can improve both or all conventional treatments. So the take-home message: tumor microenvironment is hypoxic and inflamed and resists treatment. Tumor reoxygenation therapy can enhance current therapies, and hyperbaric oxygen will be needed. And I think, you know, at this advanced stage with metabolomics and gene therapy being used, to think back on Dr. Hunter's insight, and that inflammation itself is not to be considered a disease, but is a salutary operation. But when it cannot accomplish that salutary purpose, it does mischief. And I think that's what we see within the tumor microenvironment, is that hypoxia and inflammation are continuing to cause mischief and poor outcomes. I thank you for your attention.